Hello, Assalamu alaikum. Welcome to another episode of Health is Wealth. I am your host, Shabnum Riaz. Today we are here at Maroof International Hospital and we are going to talk to Dr. Tehmina Rehman, who is a consultant gynecologist and obstetrician. Let's have a chat with her about what these two specialties are, what is the difference, and why women need to look after their health. Let's go and have a chat. And as I said before, it's lovely to be here, and we are now going to talk to Dr. Tehmina Rehman. Dr. Tehmina, thank you so much for giving us the time today. It's lovely to see you.
Lovely to see you too.
And, I didn't go into her designation because it's a bit of a tongue twister for me. So let me try. Consultant, gynecologist, and obstetrician. I got it right.
Well done, bravo, bravo, you did that. Got it.
Okay, that's great. Okay, Tehmina, tell me, one thing that, people tend to get confused about, obstetrics and gynecology, are they two different things? And is it all about just having babies?
No, it's not. Certainly not all about having babies. Obstetrics is to do with babies, the birth of babies, the management of mom-to-bees, and the management of mommies who just had a baby. So all that covers obstetrics, and a patient having any problems while she's pregnant.
Okay.
That's all obstetrics. While gynecology covers everything else, that the specific women systems, the gynecological parts that can go wrong with them.
Okay.
Right? So when you talk of obstetrics, it starts even before the patient is pregnant. She should be coming in for a wellness check to make sure she's ready to be pregnant. Then all the checks during pregnancy. Then the process of delivering the patient, whether it's abdominal birth, cesarean, or a normal birth. And then after the birth, looking after the mom and the baby, especially the mommy. So, and gynecology is to do with hormonal disorders, menstrual disorders, fertility issues, tumors, cysts, fibroids, the whole spectrum, and that also includes surgery. And surgery is open as well as laparoscopic, which is keyhole surgery. And a misnomer patients often come to us with is laser surgery. There's no laser involved.
Okay, it's
The
that's
laparoscopic surgery is what they call the laser surgery.
Okay.
So that's, and another skill that we are supposed to be having is ultrasound, both for the pregnant patients and the non-pregnant patients. Actually, gynecologists and obstetricians have this whole range of skills, from obstetrics to surgery to ultrasound to medical management.
You're doing a lot then.
Yes.
Yeah, I
It's
would
a
say
fascinating field.
Yeah, because one tends to focus on the having a baby stuff and the pregnancy, whereas it's a whole dimension that you've just spoken about. Now, Tehmina, tell me this, something that I think is very, very common in our society. You mentioned the reproductive health of a woman, and even before getting pregnant, getting to know that everything is okay. Why is it that women, especially before marriage, they will, we don't have that culture of bringing in a young girl who's going to get married and actually taking her to a gynecologist, getting her checked up to see if there's anything wrong that can be dealt with before she wants to try to start her family. So could you tell us something about that?
It would be great if people realized how important that is. But what I've seen is that young girls are mostly healthy, and families tend not to bring them before they get pregnant. The first time they often visit us is with a problem. The problem, if they're not married, it could be menstrual disorders, and now there's polycystic ovarian syndrome and things like that. So a well women clinic, whether it's to plan a pregnancy or any other part of life, that's certainly not a concept here. Even in the West, it's a concept that care providers struggle with. Even if we go through all the awareness campaigns and everything, patients just don't find maybe the time or the
Or
inclination.
priority.
It's not a
Actually,
priority.
I think that on our part of the world,
It's a
what
part of
happens
that.
is, I don't know what the reason is. What this Eastern burden we have with is that we think we can put ourselves right at the end of the, at the end of the list, and think that we can manage family and children and a house and a job while we don't take care of ourselves. We'd be more than willing to take the children to a doctor or take anybody else or deal with something going on in the home. But when it comes to looking after ourselves, why are we putting such a low priority?
I think it's our culture. Women tend to eat last.
Yeah.
Yeah. In
Yeah.
the homes, they are the last ones to have food. They often have just the cold leftovers. So I think in healthcare also they get the cold leftovers
Yeah.
when it's
Yeah.
absolutely necessary. Okay, if we look at the young girls who are about to get pregnant or planning a pregnancy, there's very low risk. Even if they don't come to us, I mean, we would encourage, but at least bring them during the pregnancy as soon as possible, because often they bring them very late as well. Yeah. But the other wellness clinic, the other thing that is I'm actually very passionate about is women's women clinic or women's wellness clinic, whereby they come just to make sure they're doing all right.
And
right?
what age should they start coming to this clinic?
As soon after puberty as possible.
Okay.
Why not a scan every year? See, there are 3 female cancers that can be screened for. One of them is cancer of the ovaries, cancer of the cervix, and cancer of the breast, right? So annual checkups can pick up these, they would be screening checkups, and they would be picking these up early enough so that they are not actually full-blown cancers, and they're picked up much earlier. And we can do a lot.
And so much depends on the early diagnosis of such
Absolutely.
cancers. And
We can offer so many solutions that are not radical. Yeah? And saving a woman, actually, though she may be a low priority as far as getting her health care is concerned, is she's the one holding the household together. The woman falls sick, and something like cancer can really destroy the family. And let me give you an example. We don't do a lot of screening for cancer of cervix.
okay.
Right? That is pap smear, you may have heard of it. Yet, cancer of cervix is very common here.
Okay.
Why? Because we only see it when it becomes a cancer.
Right.
In the West, they're picking up by screening. It doesn't progress to cancer. So less cancer of cervix. Same for breast cancer. We are not screening for it. So we have more breast cancer, because we just get them once there are lumps and they're spread. There's so much shyness, there's so much stigma, they just don't come.
And then, of course, they're dealing with it afterwards anyway.
Yeah.
So by just, it's the ostrich syndrome, isn't it? Just burying your head in the sand and thinking that, if we don't think about
It won't happen.
that won't happen. Whereas it's so important for a person to be proactive, to have that. Then that's about a mindset, isn't it? We're talking about a mindset then.
Yeah.
That you are having the precautionary mindset where you think to yourself, again, we go back to the priority. They have that saying, a woman's work is never done. So why are we so fixated with work, and why do we not understand that it's time to get your health in order? Then you'll be able to look after the house, family, and everything else.
I think on the one hand, we deal with the hypochondriacs that are coming to us with the smallest thing, right?
Yeah.
And they walk in the door, and one can tell, what am I'm going to be dealing with.
Yeah.
Then there's this whole other world where people come only when things get to that stage,
Yeah.
where they really need help. So I would just if there's one message I can give as far as screening is concerned, see your gynecologist once a year.
Once a year.
All right?
Okay. Very important
Just
message.
see your gynecologist once a year. Let her tell you
Yeah.
how frequently you need which scan, how
Right.
frequently do you need your smears. Let her make a program for you based on your history and your risk factors.
And what age are you talking about? Again, this is for unmarried girls as well?
As well.
As well.
As well. I would
Right.
suggest so that they get into the habit. See, if we have a record from before,
Yeah.
then we have something to compare with. If something changes in her cycle, we have an earlier scan that tells us she was fine and now something's changed.
Very, very important point.
So I think the sooner the better, and just one visit every year.
One visit every year.
That would be
and that is so important. What Dr. Tehmina is saying right now is for a woman to be proactive regarding her health. She needs to see a gynecologist at least once every year, so that if there are any problems, for number one, they will have a history that they can go back to, and they will know, what medical status they've been in. And second, if there's anything going wrong, they can find it straight away. So that is really important advice.
Thank you.
Yeah, right.
Thank you. I hope someone listens.
I'm sure they will. I'm sure they will. You just never know the power of one voice.
Absolutely.
Yeah, it makes such a
Absolutely.
difference.
Absolutely.
Okay, so when you see your patients and everything, is this something that you see more often, strikes you as, okay, this could have been avoided? Is it something to do with lifestyles, something to do with other things? What do you see a lot that you think, okay, this isn't such a big problem if it hadn't been dealt with before? Is there anything like that?
Two things come to my mind.
Okay.
Let's talk about the hormones.
Mm-hmm.
All right? Everything in life impacts your hormones via your brain, because stress and brain, all the chemicals that generates in the brains, it affects all the centers that control your hormones, right? And due to the changed environmental factors, somehow we are seeing more hormonal disturbances. So
What do you mean by environmental factors?
all right, let me elaborate. Diet, stress management,
Okay.
by exercise, by hobbies, by getting away from the screens, from the influence of the social media. All these things generate stress, and you need de-stressors in your life. And I see very young girls getting into developing hormonal disturbances like polycystic syndrome, polycystic ovaries, but also a whole lot of other metabolic syndromes.
Okay.
Only because they are leading different kinds of lives now. Their diets, their sleep patterns, their stresses, and you have no idea, and maybe you do because you're well-read and well-informed, that stress is increasingly being blamed for a lot of physical disorders.
I would say the majority of it, isn't it?
Yes.
You come back to stress.
So, looking after your diet, staying away from processed food, so avoidable, so
Right.
manageable, and so much is prevented. That's the one thing. But the other is that something I'm again very passionate about is the menopause.
Oh, yeah. Nobody talks about this.
No.
I mean, and then also, this is very interesting. What happens is that you usually have the scenario in a family as well, or wherever, where they talk about, aunties are just like this, always irritable, they're always angry, they're always this, they're interfering, this happening, that happening. They're not really understanding the whole emotional and physical burden that they're coming through, and how much menopause is such a huge factor in this. Tell us a bit about this, Tehmina. It's very important.
Oh yes, I would. I would really like to. So, why is it so important? Due to the longer lifespans, women are now spending 1/3 of their lives on average in menopause.
That is 1/3? That is a huge
You see,
part.
1/3 of their lives is now spent in the menopause. So everything that happens at that time, the hormonal changes, impacts every bit of her life. And so much can be improved upon.
Okay.
So, understanding what menopause is,
Yeah.
understanding all the measures, the non-medical and medical measures that you can take to alleviate a lot of these symptoms, right? So the non-medical is exercise, diet, and other substances like caffeine. But the medical is the hormones. They had been vilified for the last maybe about 3 decades. And honestly, in a woman who's screened properly, we can safely give her hormone replacement therapy, and her quality of life goes up. her skin, her hair, her moods, her
Which is so important.
let alone the hot flashes and all. But most importantly, the thinning of the bone, osteoporosis, that's prevented. That affects more women later in life and causing fractures, stress fractures, leading to early demise even, because then multiple systems shut down because she gets bedridden. The fear that was generated a few decades ago by some studies that were not conducted properly, the fear of certain cancers being increased by hormones, has just implanted this in the women's memory that they are not to take hormones.
Okay.
Right?
Yeah.
And that is so unjustified. The chance of that happening is
Very low.
very low.
Right.
But the chance of breaking your bones because they are thin and powdery later in life is much more increased. And so I feel that women need to understand they should get help, they should get hormones if they are screened and they can get it. Please do. Have a better quality of life.
That is so important, the quality of life. Many times we do not think of this. We're sort of like, okay, things are going on, just let them go on. Okay, my bones are hurting, okay, joints are creaking. You know, the sort of mentality we have is
live with it.
Live with it, or jalne do, you know, as long as we can do our everyday activities. We don't think ahead. We don't think about what's happening. Now, what you were talking about, the hormone replacement therapy, this is mainly due to a drop in the levels of estrogen, is it?
Yes,
that
estrogen.
Causes all these problems that you were talking about. So for women who have had menopause or undergoing it, that is when they should start the therapy. Speaking to the gynecologist, when should they be taking this?
Very good question. There is a period before the menstruation stops. It can be a year, it can be 4, 5 years, 7 years, where things start changing and the cycle changes, but the hot flushes, which are called the vasomotor symptoms, they start. She can get help even at that time. She doesn't have to wait for actual menopause.
Okay.
She can have help at that transition time, and not suffer those. The mental issues, the mental fatigue, the mental fog, the mood swings. Women who are working suffer the most because they are dealing with the world which is not understanding what they are going through.
Yeah.
So absolutely, I would strongly recommend, if you are at that age, perimenopause, not yet hit menopause, developing symptoms. Actually, if you're going to your gynecologist every year, as I first recommended, you would be addressing these things.
That's when you would, in fact, know in advance, so many years before. Because what happens is that when you're in the childbearing age, you're just thinking of pregnancies, okay, when you've had your children, then you're thinking about them growing up, you're thinking about their schools, then you're thinking, you know, the culture that we have, you're thinking about their proposals, how they're going to get married, and when have you taken the time to think about yourself? You haven't done that. And that is when, all of a sudden, everything comes crashing down on you.
And it's just like a domino effect.
Yeah.
One thing to another, and the body is a miracle, the way the human body has been made. So many fine things working together, but because they work together, one of them goes wrong, the others just fall like dominoes.
Yeah, like a house of cards.
Absolutely, the domino effect.
Okay, that was a very, very interesting and very important topic that we spoke about. I want to come to another question now. Lots of people say, you know, when you talk to them, if their children or somebody they know is expecting, and after they've had a baby, or maybe before the baby, is it going to be a normal delivery or a cesarean? It seems like about, 30 years ago, if it's sort of vague, if you put a time period on this, you had lots of women having normal deliveries, whereas compared to that nowadays, it's sort of like every second, third woman is having a cesarean. So people usually ask, was that necessary? What could they have, is it something to do with lifestyle? Is it something to do with our part of the world? Or is this a global phenomenon? Tell us about that.
First off, 30 years ago, same complaints.
Really?
Yeah, I started this field 30 years ago. We were asked the same questions at that time.
Really?
Right,
Okay.
and we were struggling with high cesarean rates even at that time, and hospitals and administration was questioning us even at that time about the cesarean rates.
Okay.
So when the first cesarean was done, it was done to save a baby.
Okay.
Because at that time there was no anesthesia, nothing, so the mother couldn't be saved. With the advent of anesthesia, we started doing more and more cesareans to save babies and mothers.
Okay.
As long as that was the reason, people accepted it. A few things that I've experienced, in my own experience, which I've seen that have contributed to more cesareans, yes, sometimes the doctors make the decision for their convenience, but it's not as often as they're blamed. Certainly not. Right?
Okay.
I am one of those, my statistics for normal births are really good. But I actually at times have to fight the family.
Okay.
The ones who wanted a normal birth then don't want to see their daughter in pain. They want me to operate, right?
Okay.
And then I tell them, if you've committed me to labor, I will only operate to save the mother or save the baby, not because you wish to do so now. So one thing is that the girls themselves are not willing to take the pains. A lot of them request cesareans a lot more. And cesarean by choice is a thing now.
Okay.
Right? If a patient requests that she wants a cesarean, we offer it because it is now so safe.
Okay.
So that's one thing.
Right.
Then unless a strong effort by the doctor, by the labor room staff and by the family is made in the first pregnancy to deliver them normally, it's not, and you end up having a cesarean, the chance of a second cesarean is increased, of course.
Okay.
Because we can't do as much in the second time. So the first baby is the one where
Is the decider.
is the decider, and you must, as a family member, make sure the patient is mentally and physically ready for it. Physically means if someone's a couch potato all their lives, it's not going to happen. It's not. In fact, those with sedentary lifestyles but living in areas of the world where they sit on the ground more, deliver normal more,
Right.
because
In a
somehow
squatting position.
squat, because they,
Right.
they sit and they squat and they
Right.
sit cross-legged, the pelvis seems to open more.
Okay.
So even with sedentary lifestyles, that helps. And in the West, where they don't sit on the ground, they carry all that shopping, they walk around, they're active, and so they deliver more. We are in the middle. We are sedentary couch lifestyles.
Oh, wow.
We are not really moving around a lot, and so things tend to, so physically they are not better prepared. Mentally, the girls are not willing to take the pains. Neither are their families.
Okay.
And of course, the one by choice, whereby everyone chooses because of social reasons or whatever. If they request it before they go into labor, we do it.
Okay.
No questions asked.
Right.
And that's
right.
increasingly the norm all over the world.
Right. More and more mothers prefer to have cesareans, whereas it's major surgery.
It is, and yet it isn't, because there is a cut. The uterus is also opened, but there's just, you go down, you get the baby, you come out. The skin incision is there, and there's one uterine incision. It is major surgery, but now that it is so safe, we can offer it even as an option. Because we have to understand, the normal birth is also very traumatic.
Yeah. That is something no one talks about. Because I think, you know, it's sort of understood that pain is going to be a part of delivery, so just bear with it and just get through it.
And whatever trauma happens,
Yeah,
happens
it
because
because it's been happening since centuries. That is what you hear all the time.
Yeah.
But our mothers, our grandmothers, our great-grandmothers, they didn't have epidurals, they didn't have cesareans or whatever, you know. They all had natural, so why can't you have a natural baby? I mean, there is that attitude as well, isn't there, sort of?
this is there, but cesareans, mothers and babies used to die. And that was the reason cesarean was offered. And even Queen Victoria took chloroform for one of her labors because it was there and she could have some pain relief. So we now offer epidural as well as Entonox, which is a gas during labor, for pain relief. And we encourage, really work hard at encouraging vaginal births, but the patient and the family has to be committed to it as well.
Right.
And in my practice, just 2 reasons during labor: to save the baby, if the baby is in trouble or the baby is stuck, because mothers generally are safe at that stage.
Right.
So I think the whole mindset around blaming the doctors for the increased cesarean rate has to change, please. It's not all us.
That's a good, well, you couldn't have spoken on a better platform, so
Thank you.
everybody's heard your voice there. And it's good to get the other side across.
Yeah.
Because what we hear are the patient's complaints, you know? And that's why I asked you this question, because this is something you just hear all the time.
Yeah.
That, oh, you know, this is what
the
happened.
volume of complaints is always louder, you know?
Yeah.
Complainants are always, they may be few,
Yeah.
but they're loud. And people for whom things go well, they hardly speak about it again.
That is so true.
So one of the things, for example, contraception, there are so many myths surrounding different contraceptive methods, and people have these unfounded fears because this one lady that they spoke to had this problem. The thousands of others she may have come across have never spoken of it.
Bad news travels fast.
Fast and loud and, you know, all over the place.
That's
So
true.
that's another thing, that there are so many myths and negativity involved with all the methods of contraception. It's very hard to talk about it. We speak to every patient who delivers with us and offer all the contraceptive advice, but they come back pregnant. They don't listen.
What can you do? And sometimes it's because of family pressures as well. Because other people aren't listening, even if they might be saying something.
At times, yes.
Other people aren't listening to them.
That
again.
adds to it. Yes, that adds to it. I am very happily surprised when a mother-in-law brings her daughter-in-law and says that I want her to be protected because I want her health and we want to, and I really appreciate it when the girl gets this kind of support from her in-laws, and really I compliment them, I acknowledge it, encourage it.
That's so true.
But that's rare.
Yeah.
Just so many things that we need to create awareness about.
Well, you're doing it. Aren't
Thank you, thank you for giving me this
That's what
opportunity.
we're doing on this program, because you just never know who's listening, who's watching, and it makes a difference. So changing even one person's life is a huge thing.
We try, and it's people like you who give us the platform to get the word across, and I appreciate what you do.
Oh, thank you so much. And it's guests like you who are so articulate in explaining what actually is going on, because what usually happens is that when you have a medical background, speaking in layman's terms
it's
sometimes isn't easy, is it?
Easy,
So, but you're so good at that.
Thank you so much.
Another thing I wanted to ask you, we have so many cousin marriages.
Oh, yeah.
Would you say that that is sort of like wreaking havoc as well on family structure, women's health, abnormal births, things like that? What can we do there?
So, the first question I ask, or maybe the third question in my history taking, age of the patient, how long has she been married? Is it a cousin marriage? That's how important it is, right? I need to know because it increases the risk of miscarriages.
Oh,
and why? Why do you think that happens?
Because
Let me
of
ask
the
you a question.
genes?
The genes cause abnormalities, and it's the way of nature that abnormal fetuses are aborted.
Ah, imagine.
So Allah Ta'ala has the system in place where any genetic abnormality is expelled.
And is it around about 1 out of 3 pregnancies that end up in miscarriage, or is that
I
right?
don't have the, I can't say. No, I can't, not at the top of my head.
Okay.
But let me put it this way.
But it's common.
Miscarriages and cousin marriages are very common.
Right.
And recurrent miscarriages.
Okay.
And then, yes, the rate of abnormalities found in the babies after birth, because not all abnormalities can be picked on ultrasound.
Right.
That's another thing patients need to understand. There are structural abnormalities that we can pick on ultrasound, but the functional abnormalities, if the liver is not working properly, or if they're not able to see properly or not hear properly, we will only get to know once the baby's out.
Right.
So we have our limitations. Medical science has limitations. We don't have all the answers. We have made huge progress, but that's only told us how little we know. When infertile patients ask me, doctor, there's no problem, why are we not having a baby? I tell them, it's not that you don't have a problem. You may have a problem we are not able to diagnose yet.
Right.
We're working with the knowledge we have. There is so much out there we don't know. And so every day, I read more now every day than I would maybe even last year, because there's so much knowledge pouring in, so much evolving, yet the basics in most matters remain the same.
Remain the same, okay. You spoke about infertility. Tell us about that. You're doing something very interesting, you were telling me the other day. So,
yes, I have used to work in vitro fertilization, IVF, test tube baby, ICSI, all the names that it's known by. I worked for a while, then I didn't, but now in the recent past I've started again.
Okay.
The reason I mentioned it because I'm really working hard at it, and sort of it's something else that I had wanted to do for a while, and now I've got a place where I've got the facilities, and we're offering so much more. When we talk about genetic diseases, we can offer screening. When we do IVF, when the embryo is at the cell stage, we can pick up a cell and do screening for genetic disorders.
From a cell?
Yes.
Oh my God, that is fascinating.
So where there are genetic disorders rampant in a family, or the history of previous children, we can offer that. There's so much advance in science and genetics.
So what patient would come to you for that then?
Patients would come, so there are two types of patients. Those with fertility issues, who then think that because they have certain issues in their family, or maybe not, but because they're conceiving after a long time, they would like their fetus to be screened, and only the ones screened for all the diseases and all good should be put in the uterus. And then there are those who may not be having fertility issues, but they're having recurrent miscarriages and maybe a genetic disorder that's been identified, and we could offer it to them as well. But that's few. Mostly they're the people with fertility issues that we offer it to.
Okay.
They're the ones who know about it, actually. Most people don't know.
Right, right.
But there's another thing. I'm so glad I remembered. Thalassemia. You know the blood disorder thalassemia. If the mother and the father both have thalassemia trait, there is an increased chance of a baby having full-blown thalassemia, which is thalassemia major.
Right.
So the parents have thalassemia minor, the child has thalassemia major.
Okay.
The only way we could diagnose it earliest would be chorionic villus sampling, where we'd put a needle in, take a sample of the placenta, send it for testing. But at that would often lead to miscarriage itself, because we were fiddling with it. The test came out negative, but the baby was lost.
Okay.
Right? So now we have non-invasive tests for that. I only found out about it myself a month ago. So I've so far done it for a couple of patients.
Right.
And it is amazing that we are able to do it without harming the baby. So I just wanted to put it out there that that's there. So anyone with risk of thalassemia need not be scared of getting tested because they may lose the baby. We can do it without that.
Fantastic. As we were talking about infertility, and many of the infertility drugs do lead to multiple pregnancies. We see this as being very common around the world. What about Pakistan? Do we have many multiple births, and if so, how many? Because you see a lot of this on social media.
Not as many as I feared we would be having, because at one time LHVs were prescribing fertility medicines, like giving them away to patients, and there was a time, there was a small epidemic of multiple births. But I think that's under control now, and people are a little more aware, and they're not taking those medicines, because though it sounds fun that you're going to have twins, it's a tougher pregnancy.
I know.
But tougher.
I've had them.
Yes, you would. Yes, you do. Yeah. So twice the problems and all that. And of course, the risks increase with multiples. It's now, the triplets are very hard to manage, quads are even harder. So even when doing IVF, we just put in 2 embryos and hope at least one takes.
Right.
Initially, they thought, that's why you used to hear of 6 babies or 8 babies being born.
A lot.
That was because many embryos were put in just hoping that, something takes off, and then all of
And
them
then
would
they
start.
all did.
They all did. So now we limit to 2.
All right.
We don't put in more than 2.
Okay. So all this talk about babies and everything, and we have to go and visit now the labour room and the NICU as well, you said, and you're going to show us around the hospital. We will see some patients and how everything works, and what a wonderful job you're doing, and your whole team and everybody.
Oh, a wonderful team.
Yeah.
A wonderful team. I think
fantastic.
And one thing I will say is that we have a multidisciplinary approach. When we do laparoscopies, we do with other laparoscopic surgeons, we do fertility treatments, we talk to each other, we work together as a team. So yes, let's go.
So thank you, Tehmina, for sitting down with us and giving us such important, I would say, essential information for every woman. The one you said about, that really, really went to my heart is that seeing a gynecologist every year. Imagine if people did that, how much they would pick up on. That is absolutely fantastic. And thank you for taking out the time and sitting down with us. And now we're going to go head off, see the hospital. This is Maroof International Hospital. And we can have a look at the labour room. The NICU,
yes.
Let's see what else we can discover.
Let's go.
Let's go. Okay, so we're in the NICU?
Yes, the NICU, the NICU, and as you see, there are lots of incubators, a lot of ventilators, and we're very happy. A lot of our babies have gone home.
Oh, lovely.
But we have 2 little ones here, and they were both born at 28 weeks. Around a kilo each.
28
In fact,
weeks.
this one was less than 900 grams.
And so 28 weeks is like how many months?
Not even 7 months.
Not even 7 months. Wow.
Yeah. So these babies, this one has been there with us for just over a couple of weeks.
Okay.
And doing well.
This was also preterm?
Both preterm, both 28 weeks.
Okay.
Both doing well.
Okay, that's fantastic.
Both around a kilo. And mashallah, they should be going home. This one's been with us for 37 days. And he was not even a kilo. He was 900 grams.
So you were telling us that this little fellow he was born at 28 weeks, not even 7 months.
No,
Wow.
actually, it's every 3 months is 13 weeks.
Okay.
So 6 months is 26 weeks. This little one is just 28 weeks. But now he's older. He's been with us for 37 days. And he was born at just under 900 grams. And mashallah, as you can see, he's wriggling around and he's doing well. So these are our little miracles that keep us going.
Really are miracles, and everyone who is working here are angels, honestly.
Sometimes Allah Ta'ala blesses us with that feeling.
Yeah.
So yes, it is
Fantastic.
amazing.
Wonderful.
So let's go to the labour room now.
Let's do that, yeah. That is a word that many women will react to in a sort of a, oh my God.
Yes, I can understand.
Yeah, so let's go.
Chale. That way. So this is our labour room unit.
Okay.
We've got 4 labour rooms at present. We are making 2 more with bathtubs
Okay.
for increased comfort, so that patients can spend a large part of their labour soaking and being relieved and relaxed.
I haven't heard a lot about that happening in Pakistan.
We were going to make them here on this side of the passage.
Okay.
We're going to
So once a woman is sort of like she's expected to deliver or she started her pains, this is the first place she'll come.
Yes, in an emergency, she comes here. The duty doctors assess her and then inform the consultant whose patient she is.
Right.
And the rest of the management is done by the doctor on the floor in consultation with the doctor in
that
charge.
they're seeing. Okay.
So this is one of the labor rooms.
Right. Let's have a look here. So you were mentioning the different types of pain relief. We all know about epidurals, but you were mentioning gas as well.
You know about epidurals, but again, people have this misconception that it leads to back pain. It doesn't. Back pain happens in women who have not had epidural, because that's part of the process of the hormonal changes and bad postures. In epidural is very safe. We've been giving it for more than 50 years. So that's the one choice.
One myth busted.
One myth busted, and
Right.
one clear choice of pain relief, so that, because we don't know, 8 hours of pains and then she may land in a cesarean because the baby gets stuck,
Right.
So
Okay.
one option. The other is, which we are offering, is Entonox. Behind you there is a cylinder,
Right.
and this is nitrous.
Uh-huh.
You must have seen in the movies the dentists abroad using this
Yeah.
gas.
Is that
in
laughing
dentistry.
gas?
Yes. It's not leaking right now. And so the patient can take little puffs of this and have a lighter feeling and some degree of pain relief.
Laughing their way through delivery, huh?
Yes, yes, yes. Imagine if it leaks. That would be so fun. So that's
Right.
it for the labor room. And if anything you would like to ask about?
Basically, is there some moderation to that, or can a person use that freely?
Yes, yes. I think mostly it's patient's choice.
Okay.
We let them decide when they need
Right.
it. Sometimes when patient has an epidural, she's not like zero pain.
Okay.
She has some pain. So if that is intolerable, she can add it to this. This
Okay, she can
offers
have
us
that
an
too.
option. So she can
Right.
soak in the bathtub till she's ready for the epidural, then take the epidural, and when the pain gets really hard, she can go for the gas. And so she has all these options to make her comfortable, because till we deliver the baby.
And that's really good, because then that will make her feel she's in control
Yes.
of, she's getting options to deal
Yes.
with the pain. So that is,
Absolutely, and especially
Yeah.
first timers, we don't know till the baby is out. The
Yeah.
baby can get into distress, the baby can get stuck. So if she's relieved of the pain and then she has to go to a cesarean, she doesn't feel that she's going through two types of trauma, the
Right.
labor pain as well as the surgery.
Right.
She's at least been comfortable through one.
You mentioned surgery. I think our next trip is to the OT now.
Yes.
Let's go.
Let's do that.
Okay, so now we are going to the...
Operation theatre,
Right, and that's on which floor?
first floor.
First floor. Okay.
We'll see the ICU as well, the intensive care unit, and really it's beautiful, well run, very efficient.
Right.
So I would like you to see that.
No, definitely we want to
Our
see
pride.
that. Yes, great. And of course, one of the most sensitive places in a hospital.
It is, and
Yeah.
it's really very reassuring as a surgeon that there is a place that can take care of a patient if it's a complicated patient, which we often get. It's a tertiary referral hospital.
Yeah.
We get patients who have multiple issues going on and do require ICU care.
Right,
So we'll go there now.
right.
Yes. This is our
Tehmina.
daycare unit.
Okay.
When we are not planning to keep patients overnight, Assalamualaikum. So we keep them here, and so as you can see, the nurses can keep an eye on
Right.
people inside.
Right.
It's for all specialities,
Okay.
but it's very convenient. And so let me show you one of them.
Right, let's have a look. So, Tehmina, this is the daycare centre that you were telling us about.
Yes.
And this is basically for people who've had a procedure, a surgical procedure, but they're not staying the night.
Absolutely, they're otherwise not infectious or anything. People who are minor procedures, they come in the morning, get admitted, leave by evening, and they're well monitored and well looked after. Just as this gentleman who's about to go,
Right.
and he's had a good experience.
That's great. And this will also then cut the cost of somebody staying
Of
overnight
course.
in a room or something.
Of
So
course.
it's budget friendly as well.
Very, very. And for us also, it's a good place to have so that we don't take up the rooms where
Right.
people have to stay longer.
Right.
So this is a good place to have in the hospital where people come in and go and quick turnover.
Right. Great. So where are we off to next?
Now we go to first the ICU and then the operation theatre.
Let's go. Okay, so Tehmina, now we are in the ICU, the place with all those machines and beeping noises and everything. Everyone here has a really, really responsible job. I mean, it's so important for them to be alert. Please tell us about the team here as well.
Mashallah, we have a very competent team, and they are round the clock. They have all the most serious patients here,
Yeah.
and they're all trained specially for this, and they are really top of the line. Alhamdulillah, very good recovery, and we obviously get the most seriously ill patients here. As I said, it's a tertiary referral center.
Right. And those screens, those are the monitors of the patients right now that you have?
Yes.
So you can see outside? Okay. Okay, right.
So they have central monitoring,
Right.
and each unit has every single facility. They're discussing a patient right now, and this is a very important part of the management, the whole team working together.
So right now we're in the operation theatre. Tehmina, tell me about the theatres you have here, and you told me that some surgeries are going on right now.
Yes.
So they're all full?
We have 4 operation theatres, and 3 of them are very busy right now, so I don't think we'll be going in.
Okay.
So, but next time.
Okay. Tell us a bit about how many patients on average you get here, if you know, because or maybe that would be the people here who could tell us about how many patients you get. How many operations do you have sort of
in
on an average
gynae
day?
alone? Maybe we have 100 cases or so.
Per day?
A month.
A month. Right,
A month.
Right.
In gynae alone. So we have general surgery, orthopedics, neurosurgery. So then the number is huge.
Everything
and most
is
of the
going on,
day, all the theatres are booked. The 4th OT is the emergency OT. That's for the cesareans and other emergencies that cannot wait.
Well, Tehmina, thank you so much. You have taken out so much time for us today and have spoken so well on a subject that I think is so important for so many women out there to understand that their health should be a #1 priority. So Dr. Tehmina Rehman, who has been with us today, thank you so much for being here with us today and giving us so much valuable information.
Thank you so much, Shabnum. Always lovely chatting with you.
Same here. And any message you want to give to our viewers who are watching?
I think the message that I've already given, please come in for annual checkups. And once you're here, we'll tell you about all the things that we can do to improve your life and make sure you remain healthy. Thank you.
Thank you so much. And with that great and very important message, we will leave you right now, but see you next time. Stay happy, stay healthy. Bye-bye.